Good afternoon. It is my honor to record this presentation virtually alongside Jennifer Charan and present on the topic of patient and provider perspective on 28 years of home infusion and catheter maintenance. Before I begin, I would like to thank the University of Alabama at Birmingham, UAB, for helping me record this presentation. I am in their studio right now. I'd like to thank Marcus Burnett, who we are calling the IT guy for NAHC conference. He does not know he's even getting a shout out. And of course, Jennifer Charan to present alongside with. When we are born, we are expected to reach milestones. Cry for the first time, walk for the first time. As we get older, it's going to school, reciting our multiplication tables. At 16, there's the big milestone of driving a car, and we hope to eventually start a family, get married, have jobs. Those milestones are expected. For many of us, we go on with life passively, not realizing that reaching those milestones is a miracle of our mind, a testament to our inner strength. Some just call it luck. I stand before you today telling you that it's not just luck. It's hard work, determination, passion, commitment. What do you do if you know the day you are born, you have to fight for every minute of every day moving forward for those milestones, small and big? I simply like to say we defy the odds. When I was born, the odds were against me. I was born with a birth defect called ileoatresia. As a 2-day-old baby, I immediately was rushed to our nearest children's hospital, where I had surgery, and the result was extensive. We found out that the ileoatresia was severe, and I was not born with all of my small intestine, and what remained was anatomically and physiologically inadequate. I immediately became dependent on TPN and enteral nutrition. I was in the hospital for months. My first year of life, I was not fed by mouth. I was completely fed by IVs and tubes. We easily could have given up. But as a family, we realized that this is just the beginning. We are going to live life, but this time appreciate each day alive and healthy and fight for those milestones, small and big. This is our new normal. From 2 days old to today, I've been dependent on TPN, total parenteral nutrition. I've received the nutrition anywhere from 3 days a week to 7 days a week, partial or full calories. I've also received enteral nutrition through a gastrostomy tube in the stomach, a feeding tube, and the enteral nutrition I received anywhere from 16 hours a day, every day for 20 years. I went to school with 2 backpacks, my nutritional backpack and my academic backpack. I was called the girl with the backpack. You could call me the Indian Dora. Even today, I am giving this talk with my backpack on and with the TPN running. Over 29 years, I've had 65 surgeries. Of those 65 surgeries, 31 have been new central line placements. And of those 31 central lines, 25 have been infected with bacterial or fungal bugs. But my most proud number is it's been 11 years since my last central line associated bloodstream infection. How did we do it? How can I today say that's been 11 years? We surrounded ourselves with curious medical care providers. What do I mean by curious? Curious is committed, compassionate. They're willing to ask and answer the hard questions. My case was and continues to be very complicated. We require these committed medical care providers, clinically excellent medical care providers, but most importantly, compassionate, those that think beyond the protocol to be by my side. But more as important, my parents and I became educated. I became a professional patient. I learned how to speak up, how to advocate for exceptional standards. I cannot stress how much that has affected my care. And in this talk, I will share my journey, my experience with home infusion, but how my advocacy has changed the way I receive care. I came across this quote by Rishi Manchanda. He's a physician in Los Angeles, and he gave a very well done TED Talk, and he said, "Health is too rarely perceived as a group phenomenon." Unfortunately, that is true. But that is what we're trying to change today in medicine, and that is what we're trying to change with the patient education tool. We are trying to empower the patient, make the patient part of that medical team, part of the care group. Why is it important to empower the patient? These are questions that have been spoken about on Facebook from Emily Levy, who is the founder of Mighty Well. She's a professional and patient advocate. And she has shared these questions that I can relate to very much. And I thought they were a great way to show what your patient is thinking. Is the medication going to work for me? Will I feel the needle and or the line? Why do I feel the saline going into me? Why can I taste it? How can I shower? So many times we get the mandate to not get our lines wet because that's a risk for infection. But there's never the discussion of, well, how can we adapt your routine so that you can still shower in a comfortable way and still not get your line wet? That's a conversation I've never had with my care team. It's a conversation I've had to figure out on my own. Will I be limited in movement? I've had so many central line placements as a child while in elementary school. They were one-day surgeries. Go in on a Friday and go back to school on Monday. And I remember distinctly being on the playground and just being sore, not being able to move my neck, reach up for the monkey bars, or really being a full kid on the playground. No one told me these restrictions, but instead I learned as I experienced it. How will the line feel to be removed? I remember my first line that was removed at the bedside, and I was scared to death. I just broke down in tears at the bedside, and my dad, fortunately, was by my side before the surgeon came into the room and was able to comfort my tears. And I admitted to him that I was just scared because I didn't know if I was gonna feel the removal of the line, the removal of the stitches, and I was afraid of pain. That was the reason I was crying, no other reason. And those conversations need to be had beyond the parent and the child, but the care provider and the patient. Who do I go to for help if I have complications? Do I understand my complications? These are questions that are being answered in the patient education tool. We have language to show numbers, contacts, when and if these specific symptoms occur. Is my line infected? What are the signs and symptoms? As a patient advocate, as a healthcare advocate, I get text messages from fellow friends that also have central lines and who've never fortunately had line infections, and they ask me, is it normal to feel chills, that uncontrollable shaking? And I have to comfort them that that is normal and make sure they are taking the appropriate precautions and already in communication with their doctor. Patients are getting a lot of support from other patients, but that support should also be trusted into the clinician. Am I using the best products for me? I'm going to share a story about receiving products or learning about different products in home infusion. Is this the best product for that person's skin? Is this the best product for this person's line? Do I and my care provider know the acronym SAVE? Save My Line was a poster done by AVA, the Oli Foundation, and INS on this acronym SAVE, which is scrupulous hand hygiene, aseptic technique, vein preservation, and ensure patency. These are minimal facts that patients and clinicians and medical care providers need to know about central lines. This document is being advocated to be given to all patients and clinicians, especially through the Oley Foundation. That's how I learned about it. But this should be universally given and talked about. This is a list that I created on the role of the home infusion provider, specifically for a long-term TPN patient. And these are aspects of care that I have learned that needs to be done in a long-term TPN patient's journey, which starts with the lab draws. You will see a list that is pretty much standard of care. Protocol, lab draws, site care, supplies, phone call check-ins, and the transition of care between hospital and home when your patient is hospitalized for whatever reason. Physician referral. This is the number one thing in my social media network when asked, what is your biggest concern with home infusion care? One is consistency of care between hospital and home, but the other is physician referral. Many patients do not have access to physicians or other medical care providers that understand the management of TPN and their line. And as a result, they are struggling to find those clinicians. I believe the home infusion provider has that network, has that ability to help patients get to those physicians. The other column, which starts with my advocate and ends with transition of care from childhood to adulthood, I'm going to go through each of the bullets with stories as I continue through my medical journey. But I want to talk about transition of care from childhood to adulthood very briefly. Transition of care, in my experience and for many others with long-term TPN, long-term lines, is absent. I had no transition of care. I fortunately was in a position where I could go to college away from home and live in the dorm. I never had a conversation with my home care provider about making that transition to college, changing my living settings. How am I going to hook up my TPN? The cleanliness of my dorm room? What is my routine going to be? Instead, can I hook up my own TPN? Instead, it was put on my father, who I'm his daughter. I'm his apple of his eye, and he really reluctantly did not want to pass on this responsibility. He wanted to help me. And if it wasn't for me to actually leave the house, he probably would still have not given the responsibility to me. But it was him teaching me and me just observing his actions over the previous 20 years did I learn how to take care of myself and learn the importance of speaking up. But this transition of care, that relationship is not present in every family, and transition of care is a huge aspect of our medical journey and needs to be talked about with the home infusion provider. It needs to start with the home infusion provider. Once I went to college, I was 20 years old and I had finished my sophomore year of college, and I had one more surgery, thinking this is it. This is my last surgery, my last hospitalization. This will let me be free. This will give me the milestone of no more IVs and tubes. Unfortunately, the surgery resulted in complication after complication, surgery after surgery. We went to a different hospital. I had more surgery. It resulted in complications called fistula, which are abnormal connections between hollow spaces in our body. I had fistulas from my small intestine to my skin. I had fistulas from my colon to my small intestine to my skin, and fistulas from my bladder to my small intestine to my skin. So I was urinating food and bile, and that same food and bile was draining spontaneously onto my abdomen. I was getting burned out. I was physically beaten inside and out. I wanted treatment, anything. We as many rare disease patients have to do, we took my care into our own hands and we traveled around the country, talking to subspecialist after subspecialist. And we found that my options were limited to surgery. And the surgery that would result in the highest success for no more fistula was to take out the small intestine. It was a bold decision, but I ended up making that decision to take out the small intestine, the same intestine I fought for every day for the last 20 years plus. After the surgery, I was not able to eat solid food by mouth, and my gastrostomy tube was no longer used for feedings and instead was put to gravity drainage 24/7, and all my feedings came from an IV fluids and TPN 24/7. Even though I could not eat and I was connected to an IV and tube 24/7, I had one more goal, and that was to finish college. My home healthcare team knew the importance of finishing college for me. They saw that that was a milestone. And so they figured out the maximum calories they could give in the TPN safely, how I could give fluids and TPN in a backpack and carry that to school and have the stamina to take classes and to finish my last 3 semesters. I'm proud to say that 3 semesters later, after having my small intestine and large intestine taken out, I graduated at the top of my degree and was able to give the commencement address at graduation with my backpack on. I'm going to talk about teacher-learner, consistency of care, and triage for the ER. After surgery, or while I was going through college, my home healthcare provider, a pharmacist, gave me a call and said, "Swapna, you should go to this one-day home TPN conference at another university 2 hours away." And I was surprised that she was offering this opportunity, but I jumped on it. I said, "Yes, please, I will go." Because at the time, I did not know any other TPN patients. I knew one person that went to the same pediatric surgeon as I did, and that's it. I was not part of any Facebook groups, was not part of any support groups, not part of Oli Foundation, was not in the position that I'm in today. I went to this conference, and I immediately learned about the Oli Foundation. The first person who heard my story said, "You have to go to the Oli Foundation. Here's the newsletter. Please look into going to the conference." But then I started experiencing this one-day conference, and I got to see the other types of supplies I could use as a home infusion patient. I, at the time, was doing a non-transparent dressing. That was not the optimum dressing I could use. I learned about dressings with CHG in it. I learned about needleless connectors with alcohol in them. I learned about additional supplies that would put me at a lower infection risk. When I came back, I told my home infusion team about these supplies that I learned about, and they did not carry this dressing in their warehouse. However, because they adapted to my needs and they go above and beyond, they have ordered the supply for me, and to this day, specially order it to add it to my dressing kit. After I graduated from college, I made the tough decision to have a small intestine organ transplant. I had to accept the risk of death, the risk of complications. I had to know that this is not a cure, but rather an exchange of hardships. It was a personal decision. It was a decision in hopes of moving forward and not living the life that I was at the time that was either stay the same or get worse. And with the confidence that I could get through any complication that came my way, I made the decision to have a small intestine organ transplant. On June 3rd, 2014, I was listed for the small intestine organ transplant, and on June 18th, 2014, I had the transplant, just 15 days later. On June 19th, I woke up for the first time with a full functioning small intestine. On July 3rd, about 3 weeks after the transplant, I got to eat solid food for the first time in almost 3 years. I had my parents' homemade Indian food that I was craving every day for the 3 years prior. And 3 months later, on my 25th birthday, I had cake and ate it too. When 3 years prior, exactly on my 22nd birthday, I had to stop eating at the table and could not get to the cake because of the fistula. But among the highs, I've had many lows. As I said, transplant can be an exchange of hardships. After reaching the milestone of no more IVs and tubes and no more TPN and no more gastrostomy feedings, I lost 30 pounds and required the need to get back onto TPN, where I gained my weight back plus more. I had bilateral hip replacements due to the diagnosis of avascular necrosis, and I had fungal and bacterial infections that required more surgery. During this time, once I came back home after these complications, specifically after the transplant, I was back with home infusion on TPN, and I do all my own care except have a nurse come and draw labs. This nurse, unfortunately, I had this nurse for almost 5 years now, and we have become close friends, and she comes into my home every week, and we always update each other on our weekly activities and how we're doing. But this nurse was not scrubbing the hub for 15 seconds at a time. And I had to advocate and tell her to please scrub the hub for 15 seconds at a time. It was very awkward at first, but she responded and has done it ever since. I also advocated for her to wear a mask during lab draws as well as cap changes because of my increased immunosuppression levels. And she has. These were not types of care that she was doing before, but now this is a standard of care. And when another nurse comes, instead of her, for if she's out of town or cannot make it, she has a care plan written out for the new nurse. So there's not a gap of care. Instead, there's a consistency of care, and that is so important. Well, after the hip replacements, it was about 2 weeks later, and I was on my last dose of pain medication, and a new nurse came to draw labs. I had taken a pain pill an hour before the nurse had come, so I was a little out of it. And the nurse had come to draw the labs. He set the field. He was drawing the labs, but before he began, he realized he forgot one of the suction device to get the labs into the vial. And so he said he had to go back to the car to get the device. I said, that's fine. So he went to go to the car, get the device, and in that time he opened the door, opened his car door, came back in, opened our door, and had come back to the field without washing his hands. I was shocked. I didn't say anything. Instead, I boiled inside, and for the rest of the day freaked out that, great, I'm gonna get an IV line infection and I just had hip replacements. Why did I not speak up? Was this nurse mindful or mindful? It's so important for the nurse, the care provider, to be in the present moment, to understand the patient's need, that line is the patient's lifeline. And that for a patient, it's their life. I called the home infusion provider afterwards, later in the day, and talked to the pharmacist. I told her that I had taken a pain pill, I was a little out of it, that I didn't say anything, these are the actions that happened. And then she immediately forwarded the information to the nurse manager. The nurse manager called me within 24 hours and said she had spoken to the nurse and resolved the matter as much as she could. But then she continued and she wrote me a letter of apology for the gap in care. And then she went above that and invited me to come to the clinic or to the pharmacy and give a talk on central line care from the patient perspective for the nurses. I thought that was the best thing that could happen given the circumstances. This is a quote from a parent of a 13-year-old TPN-dependent child on the importance of knowing the reason behind our actions and care. If a caregiver does not understand the gravity and purpose of their care with infection prevention, they will not be as compliant or effective. When a caregiver is scrubbing the hub because that's the rule and not thinking about the child's lifeline and how to protect their bloodstream from infection at every access point of anything that will be going into the line or body, then there will be an increase in errors. We can't do actions because, or that's the rule. We have to go above and beyond and explain the purpose, explain the value to the patient, and the patient also needs to understand, and that's what this patient education tool is helping to do. For me, it is my life. For you, it is your job. After I got the hip replacements, my hips don't lie and I can't stop moving. And I moved to Washington, D.C., and after that have been traveling around the country doing speaking engagements and advocacy. When I moved to Washington, D.C., I stayed with the same home infusion company, but was with a different office. Unfortunately, there was a lot of lapses in care, and it was not the best experience. I have told my home infusion team that if I were to ever be located in D.C. again, it would be my preference to not be with that office. I had to explain my worries, and they also understood where I was coming from, and I updated them on my concerns as they happened. And that they appreciated that so that they could be updated in a timely manner. I continued to travel, as I said. I've been to Orlando for speaking engagements, Dallas, and Seattle. Seattle I went to a year ago. I was in DC and I was going from DC to Seattle, and it was the first time I was ever going to travel that far by myself and that far with TPN. My childhood friend was getting married and I was not going to miss it, and then I had a talk in Vancouver, Canada. Up until this point, my home infusion team did not pay for deliveries outside or wherever I traveled. Cleveland, any hospitals that we went to get second opinions, we had to pay for those shipments. Unfortunately, I'm in a position where we could pay for those shipments. And usually they're 100 to 150. They're based on weight of the TPN. Well, I'm going to Seattle by myself, and knowing that they're not going to pay, I took the delivery to the FedEx, and me, as petite as I am, had to pack 7 days of TPN by myself, put it in a suitcase so that it could be on wheels, took it to the Uber drive. The Uber helped me put it in the car, then he took me to the FedEx in the middle of the city of DC. He helped me get it out into the FedEx, and then they helped me pack it. It was quite a task. I was expecting $100 to $150, and they tell me it's $345. I'm shocked. This is more than my flight ticket, but what am I going to do? It's Friday afternoon, my flight is Saturday morning, and I need the TPN Saturday night, and you can only ship on overnight due to the stability of the TPN. I had to pay it. Well, immediately after my trip, I called my home infusion team and I said, I know competitors do not charge their patients on when they travel, and this is a cost that I will not stand for. I know other patients will not be able to afford the cost of travel if they're on TPN. And there needs to be, can we have a stipend for patients? We need to do something about this. And since that point, my deliveries have been paid for to Orlando, to Dallas, to Phoenix, and other locations that I've traveled to. My team knew the importance of advocacy and speaking and travel and visiting my friends for the first time after they've moved away. They adapted to my needs and my life. 4% of dissatisfied customers complain. 96% stay silent and leave. But 95% of customers will do business with you again if you resolve their problem quickly and fairly. And I'm that 95%. With this home infusion team, I have stayed with them for 8 years. Although we've had problems, gaps in care, lack of payment for traveling, I have discussed these issues with them. There have been improvements made in a timely and fair manner, and so that is why I stay. And their clinical expertise has been proven to me. But I had to get to that. I had to find them. I had to advocate for that. Because before that, I had to change home health care providers. I've changed 4 times. It's important for me and for fellow patients to live, not just survive. My home health care company has seen me at my lowest, in the ICU, suffering from complications, doubting if I'm going to survive. And now they're seeing me live life to the fullest. My story is not without them. They also understand my purpose to have a career, to go to graduate school, to travel, to speak, to advocate. I cannot do this, live my life without my home health care provider. And for that reason, we need to implement patient education tools to empower the patient further so they can also have a similar story and have that team relationship with their home infusion provider. Thank you.